everyone. Good afternoon. Thank you so much for being here. So it's going to keep this hopefully interactive and just practical kind of new things that are coming along for relapsed refractory multiple myeloma, and happy to take any questions people have about the whole process. So relapsed refractory multiple myeloma. First, what is relapsed and refractory? Which means that myeloma that's been treated already and has unfortunately not responded to treatments or has come back after a period of good response. So coming back after a good period of response, that refers to relapse, and not responding to any given treatment at all refers to refractory. So that's what we mean when we say relapsed and refractory multiple myeloma. So by definition, patients who have relapsed refractory multiple myeloma have already received one or more treatments for myeloma. And they're further along in their journey in terms of treatment for myeloma. The good news in the last 10 years is that there are many different ways of treating relapsed refractory multiple myeloma. Probably 10, 15 different combinations, regimens. If you're talking to your neighbors, your friends, support groups, I think one of the themes that many patients tell me is, why am I getting this combination and not the other one? Why am I getting daratumumab and why is my friend getting carfilzomib? The reason is they're all effective treatments. These treatments work very well, but they don't work for everybody, and they don't work for forever and ever. So oftentimes I tell patients that these are all different tools or arrows we have on our quiver. Eventually, if we do our job right, many patients will need most of these treatments in some sequence. Whether we use one drug before the other, or whether we use a CAR-T or daratumumab or something else, is driven some by the biology, that is, are there mutations, deletions, are there information about the myeloma we can gather from labs, pathology, imaging studies. Some are determined by side effect profiles of these treatments. Each of these drugs have different side effects, and we may prefer one drug over the other. For instance, as many of you know, bortezomib, a drug that's used, has one of its risks is neuropathy. So somebody who has a lot of neurologic issues already or neuropathy already for other reasons, we might want to avoid that drug. A drug like carfilzomib, very effective, but can affect cardiac function in some patients. So again, if you know patients having a high burden of cardiac issues prior to starting the treatments, we may steer off of that drug to begin with. Infection risk with some treatments. So the kinds of side effects that we see with these drugs may favor one versus the other. The other factor is how quickly is the disease coming back. Some patients, the disease may be coming back very quickly with lots of symptoms. In those cases, we say we want to put our best foot forward and try to go with the most effective treatment. Others may just be diagnosed with relapse because their markers are slowly going up. The RM spike goes up from 0.1, then 0.2, then 0.3. In those situations, we feel like we have more time, and maybe we can do less intense treatments and try to get the same benefits as the more intense treatments. Probably the most important factor is also patients' own preferences. Patients may live far away; they don't want to come every week. Is there an option where they can get oral drugs? That may play a role. Patients may want IV drugs, not subcutaneous. That may play a role. With something like CAR-T cells, there's a lot of, which we'll talk in a few minutes, there's a lot of things to coordinate and arrange in the short term, but if it works well, patients can have the opportunity to be off of treatments for 1, 2, or 3 years, and that may be preferable. They'd rather come to a big center, get things done, and then not have to deal with this coming in weekly infusions. So that may be, so patient preference really matters quite a bit as well in deciding what drugs and treatments to go ahead with. And then there's bispecific antibodies, which you heard Dr. Rodriguez speak about a little bit earlier as well, and there are several choices there. I was going to give a little bit of an overview of what you might expect if you are thinking about CAR-T cells in terms of both the science but also practicalities. What's involved? How do you go about getting a CAR-T cell? And what should you know? So CAR-T cells are different from many of the other treatments we use for myeloma or cancer treatment in that they use patients' own T cells, patients' own immune cells to target their cancer. We all have immune cells, T cells that are floating around in our body. They're part of our immune system, they're part of our defense. And the idea with CAR-T cells is to take those immune cells from the body, a process called apheresis. And this is a single day process, one single day. Takes about 3 to 4 hours. We can collect these T cells from a peripheral blood, either with an IV line or occasionally a central catheter, but typically about 3 to 4 hours. Once these cells are collected, they go to a lab where they are genetically modified or engineered. And we make that genetic modification using a viral vector. So This engineering process can take anywhere from 3 to 6 weeks at this point. And the engineering process allows for us to tweak the T cells that we've taken from the patient's body to target specific proteins that are present on myeloma cells. So the one that's most commonly targeted is a protein called BCMA, or B cell maturation antigen. This is a protein that's been identified to be present in most myeloma cells in most patients. So therefore, if you target this, we're hoping we can get rid of the myeloma cells that express BCMA. So you take these cells, engineer them to target BCMA. That engineering process takes about 3 to 6 weeks, let's say 3 to 7 weeks. And once that engineering process is done, we want to put those cells back into these new engineered, refined T cells, put them back into the patient's body. Before we put the T cells back into the body, we have to give 3 days of chemotherapy, typically with 2 drugs. One of them is called cyclophosphamide, that some of you may have heard of as part of your treatments. The other one is called fludarabine, which is not a drug we typically use in myeloma. And that's because these 2 drugs are not given to target myeloma, they're given to lower the immune system so these new T cells can go in, expand, and do what they're supposed to do in the body. The 2 drugs are typically low doses. The side effects are quite manageable for these 2 drugs. We give them at our center as outpatients. So you come in to our daycare unit, get the treatment over an hour, hour and a half, be monitored, and then go home, come back the second and third day. So 3 consecutive days of these 2 drugs given IV. Once the 3 days are done, we typically give 2 days of rest. That's just being monitored without any treatments. You may still be asked to come in for hydration or labs, etc., but there's no treatments. And then the following day, so that's 3 days of chemo, 2 days of rest, and that following day is when we give the CAR T cells back. These engineered T cells go back into the body. So I'll come to side effects in a minute, but there's several things to consider here. Number one is from start to finish, this can take anywhere from 4 to 8 weeks, or even longer. So that's one consideration. The second is, right now, CAR T cells are available in a limited number of large referral centers. So because of the monitoring that's required, because of the customized nature of the treatments, it is not yet widely available, although here in New York City, there are many places that have access, but outside of large academic centers, big cities, it is still somewhat limited. So for some patients, it may mean traveling out of city to, let's say, New York, Boston, Chicago, somewhere else, to be able to access these treatments. The good news is most large medical centers, as well as the companies that make these CAR T cells, do have a lot of support programs for housing, caregiver support, to be able to relocate temporarily for 4 to 6 weeks to a new city. So I wouldn't deter, not having immediate access from asking your doctor about CAR T cells, because there are other programs that can help support the requirement. So I do think that it's a fair question for patients to ask their doctors wherever they are in their journey for relapsed refractory multiple myeloma to say, should I be thinking about CAR T cells? Not necessarily because you need the CAR T cells, but to at least make sure that you and your doctor are considering that as an option if and when it becomes necessary. The other one is because it takes this 4 to 8 weeks, we don't necessarily want to wait for the myeloma to continue to progress while we are manufacturing the T cells. So many times patients get what is called as bridging therapy. So that may be carfilzomib, daratumumab, some other drugs to hold the disease steady while the laboratory is manufacturing the CAR T cells. So that's something, again, can be done if you're living in the city, or if you're living in a center where you get CAR T cells, you get that bridging therapy there. But it's certainly feasible to get that bridging therapy with a local oncologist, for instance, because usually we use drugs that are FDA approved, that are standard, that are readily available. So the CAR T team and the doctor can talk to your primary oncologist to facilitate the bridging therapy to be done closer home. So fast forward all of this, the CAR T cells are ready, we've given 3 days of chemotherapy, and then we're now ready to infuse the CAR T cells. There they go. It's actually pretty anticlimactic. The cells go into an IV line. It's very similar to getting blood products. Takes about 30-40 minutes. The cells come in a small vial or a bag, and it's infused in a regular hospital unit. And there's really no immediate side effects. We do monitor for a few hours after, but typically most patients tolerate the infusion itself without any issues. It's the subsequent few days and weeks that we have to monitor patients very closely. If you recall from the last hour, I guess, Dr. Rodriguez talked about cytokine release syndrome or inflammation. That same inflammation we can see also after CAR T cells. So a high proportion of patients, 85 to 90% who get a CAR T cell, will develop fevers. and other signs of inflammation. Typically, those symptoms are fairly early within that first 1 to 2 week period of getting the CAR T cells, which is why you'll be monitored very, very closely for that first couple of weeks and first 4 weeks really for any of these symptoms. The good news is in the last 10 or 12 years that we've done CAR T cells, really learned a lot more about how to recognize these symptoms and treat these symptoms. So severe CRS where our patients needing to go to the ICU, more severe complications are exceedingly less common in the last 5 years, I would say. So that's good. There are many drugs we can give to counteract it. It's important to follow closely, important to stay close by for that first month, but CRS is very, very manageable. The second group of symptoms are neurologic. Again, something that Dr. Rodriguez mentioned in the context of bispecific antibodies. We see neurologic symptoms like confusion, difficulty with speech, writing, etc. in about 1 in 5 patients, so 20%. So much less common than the CRS, but can be seen in about 20% of patients. Again, we've gotten much better at recognizing it, treating it, monitoring it, and managing it. So most people, all people really, who have these neurologic symptoms in the short term quickly reverse within a few days. Very, very rarely do we see persistent or irreversible short-term neurologic symptoms. So those are the 2 main symptoms we watch for in the first 2 weeks. Slightly more longer term, the first month, 2 months, 6 months, 9 months, I think things to be worried about are infections, because these treatments do compromise patients' immune system. So we want to make sure that we're monitoring for infections. We're giving antibiotics, antiviral medications to minimize the risk of infections. The second is that there's a small risk that some patients develop neurologic symptoms several weeks to months after the CAR T cells. So this is something that's rare but serious, and one that we don't fully understand yet the exact mechanism of. These could manifest in the form of Parkinson's-like symptoms in a handful of patients, neuropathies in other patients. And some of these are reversible, some have not been reversible. The key here is they're uncommon, but when it happens, it can be pretty challenging to manage. And that's one of the reasons why even after that first month, we keep a pretty close watch for patients to see if any of these rare symptoms occur 2 months, 6 months, 9 months after the CAR T cell. The other group of symptoms we've seen are even rarer. So there's a handful of patients across the country out of the many thousands of patients who've gotten CAR T cells, where that genetic process of manufacturing the T cells may lead to a cancer itself, which is exceedingly rare, to be very clear. But again, something that your doctors will monitor periodically long term. Lastly, there are some patients who have developed diarrhea or other kind of GI symptoms a few weeks, months after the CAR T cells, some of which has been quickly reversed with immunosuppressive medications, and some that have been persistent. So these last sets of symptoms I mentioned certainly are serious, but they are quite infrequent. And with appropriate monitoring and management, we're hopeful to one, prevent these symptoms, and 2, hopefully in the rare patients that develop them, to try and reverse them quickly. It was good to take a pause and see. There's a lot that I guess we covered, so I'm happy to take questions about anything that I talked about or anything else really about relapsed refractory myeloma.
I will bring a mic around for your question.
Thanks for your comments. I have a kind of dual question about CAR T. As more and more clinicians or researchers become familiar with CAR T and its successes or failures, like with bispecific agents, is there more research currently going on to look for a different receptor than BCMA with CAR T to perhaps find that magic bullet? And also, is there any progression in the reduction in the, I guess, the production of the manufactured T cells? There was a study that was happening in, I think, China, looking at maybe a 2-week period. Is there any hope for that to reduce this time frame for production of the altered T cells?
Both good questions. So the first question refers to the fact that I talked mostly about BCMA CAR T cells, which are the ones that are FDA approved, but are there other targets? The good news is there are other targets, some of the same targets that we have bispecific antibodies for, particularly this other protein called GPRC5D. So you can think of these proteins as things that are on the top of myeloma cells. BCMA is one of the markers, but the myeloma cells also have other markers you can go after. So the other one that we have CAR T cells now in clinical trials for is a marker called GPRC5D. So that also has shown quite promising efficacy, including in patients whose disease has come back after having received a BCMA CAR T cell. So at our center, for instance, we have patients who've gotten a BCMA CAR T cell, did well for hopefully several years. When their disease came back, they got then a second CAR T cell targeting a different protein, GPRC5D, and then have gone on to doing well again for an extended period of time with that second CAR T cell. So there are other targets, some of the same targets you heard from Dr. Rodriguez for bispecific antibodies like GPRC5D or FCRL5 are things that are also being evaluated as options for CAR T cells. The other approach that with CAR T cells that we are taking and others are taking as well is to target more than one protein at the same time. So you could say, similar to drugs, you give carfilzomib, it works, you give lenalidomide, it works, why not combine the two together, carfilzomib and lenalidomide, give it together. So similar approaches with CAR T cells and bispecific antibodies, to be honest. You say BCMA CAR T cells work, GPRC5D, why give them sequentially? Could we combine the two together, or could we have a CAR T cell that targets both proteins at the same time and see a good response? So there are now clinical trials at our center and others that are looking at targeting more than one protein at the same time. And last one, I would say, is why pick a CAR T or a bispecific? There are trials where you do both at the same time. You give a BCMA CAR T cell, let's say, and then rather than wait for the disease to come back, since we know that eventually the disease might come back, could we give a GPRC5D bispecific antibody afterwards for a fixed duration, say 6 months or so, and try to get the benefit of both of those targets concurrently? So all of what I just mentioned are clinical trials, so they're not standard practice yet. Hopefully they will be in the future, but those are some of the new things that are coming along. The second question referred to the fact that we're now waiting for 3, 6, 7 weeks for CAR T cells to be manufactured. Are there efforts to shorten that time? There are. So there are several platforms now that are called rapid manufacturing platforms, where the actual manufacturing, that whole engineering process, can be done in 2 to 5 days. There's still some quality checks that are required, which means that it still takes about 14, 15 days for the cells to be ready. But you can certainly shorten the time significantly. So those are also still only clinical trials, but hopefully in the future, some of those will allow us to give CAR T cells much more quickly. Along the same vein, our group, others have looked at what is called as allogeneic CAR T cells. This means we take T cells not from the patient, but from a healthy donor, and manufacture the CAR T cells and keep them ready to go, which means we don't have to wait 6 weeks for manufacturing. We take the cells that are already manufactured and give it to patients. So those have also come to clinical trials with some promising results. So these might mean in the future that you don't wait 6 weeks, you don't even wait 2 weeks. Like a drug, you would have CAR T cells ready to go and you would infuse them. But again, we need to do the clinical trials before we can be confident that they have the same success rate as what we currently have available.
Okay, what other questions? These can be about CAR T or just
Or any other drug, yes.
relapse refractory myeloma in general.
Yes. Do we know why the FDA set 4 relapses rather than, right away if someone decides they want to do it?
Good question. So actually the FDA has updated the initial approval for patients with 4 prior lines of treatment when they first approved it a few years back. But earlier this year, both of the CAR T cells we currently have, that's ide-cel or Abecma, and cilta-cel or Carvykti, those are the 2 CAR T cells that are currently approved. They were both approved for patients with earlier lines of treatment. So for instance, Carvykti or cilta-cel is now approved for patients with just 1 prior line of treatment. So not yet approved for patients who are newly diagnosed with myeloma, but hypothetically patients who've just had 1 single course or line of treatment, some years later their myeloma came back, cilta-cel would be a consideration. Okay, that doesn't mean that you have to get cilta-cel, but it's an available option, one of many options that are available. Similarly, ide-cel or Abecma is now approved for patients with 2 prior lines of treatment, so not 4. So both have moved to earlier lines. I guess if your question is why did they first approve 4 and wait a little bit, because I think that's the nature of developing these treatments, which are very effective, but also have a lot of toxicities that we need to understand. So the initial approvals were based not on very large studies, they were based on studies done in about 100, 150 patients. It looked very promising. So the first thing that the FDA rightly decided was let's make it available for patients who don't have many other options, because in that scenario, it seems reasonable trade-off even if the side effects were high. These are patients who've already received other standard treatments. What changed earlier this year was for both cilta-cel and ide-cel, large studies were done where what I call as randomized studies, where half the patients get CAR T cells, the other half get a standard treatment. Let's say daratumumab with pomalidomide or dexamethasone, and in both with ide-cel and cilta-cel, those studies showed that patients receiving cilta-cel or ide-cel tended to do as well or better than the control group, with side effect profiles that now we understand much better, which is why the FDA rightly decided this year that both of these CAR T cells could be used earlier. To your question of can you use it in patients who have newly diagnosed myeloma, those are studies that are currently ongoing. So there are trials at our center or others that are looking at patients who are newly diagnosed multiple myeloma. They've just been diagnosed with myeloma, looking at, say, for instance, giving patients a transplant, which is one of the standard options, versus giving them a CAR T cells. Those studies will take the next few years to get results. And if those studies are positive, then there may be a potential future where we would consider a CAR T cell in a newly diagnosed patient. But the reason to be slightly cautious is our existing drugs are very, very good and effective, as many of you can attest for. So while there is urgency to get these treatments faster and earlier, there's also the need to get it right as quickly as possible. So I think this stepwise approach of steadily moving it earlier, and each step assessing what evidence we have for both efficacy and safety, will allow us to give these treatments to the most number of people and in the quickest possible way.
Okay, there was another question over here somewhere.
Do we know why the CAR T cells will often lose their effectiveness? Is it due to the CAR T cells, or is it due to the myeloma cells bypassing it?
Yeah, it's a very good question, and one that I think many research groups, including ours, has spent a lot of time thinking about and trying to understand. So there is a philosophical point, I guess, that most drugs for myeloma, they're effective, but even when they're very effective, the efficacy eventually kind of weans off for the most part. Daratumumab, carfilzomib, these drugs can work very, very well for months, years sometimes. But if you wait long enough, in the majority of patients, the disease tends to resurface. And unfortunately, that is also what we see with CAR T cells and bispecific antibodies. As you rightly alluded to, when that happens with the context of CAR T cells or, let's say, bispecific antibodies, there are two main factors one would consider, I guess. One is something about the tumor cells. So the myeloma somehow has learned how to overcome the CAR T cells. So let's say we're targeting a specific protein, BCMA. So perhaps the myeloma cells have figured out how to decrease the amount of BCMA they have on their cells. So that's one way in which the cells can outsmart the CAR T cells. Okay. And we're seeing in some patients, not everybody, some evidence that when the disease comes back, there's not as much BCMA in the myeloma cells. So in those patients, we suspect that it's because the cells have somehow figured out to decrease the BCMA levels. Now, the challenge even in those cases is to understand how did the cells figure that out? What exactly in the cellular processes allowed them to decrease BCMA? Because understanding that might allow us to say, we could potentially use drug X to prevent that from happening. We're not there yet, but that's the line of thinking. The other counterpart to that is maybe the T cells somehow stop doing what they're supposed to do. So there's this concept of exhaustion. Just like we get tired when we run 40 miles, or those of you who run marathons, or those of us who run only 2 miles and get tired, regardless, there's a period of time when we get tired. And there's a concept that if you have myeloma or patients who receive a lot of chemotherapies, maybe their T cells are like me, they can only run 2 miles before they get tired. Or if they're healthier, they're like Dr. Shah all the way back there with healthy diet and exercise, she can run 40 miles before she gets tired. So there may be differences in exhaustion of T cells, and that may predict why some patients relapse early, others later. The challenge here is it's very difficult to measure exhaustion in the laboratory and very difficult to quantify exhaustion. At some levels, most patients have a degree of exhaustion in their T cells. It's difficult to separate out why some of that exhaustion translates to short responses and others don't really lead to short responses. About several research groups, including ours, is looking at both of these aspects, the tumor cells and the T cells. And then lastly, there may be specific characteristics of multiple myeloma. So for instance, we've recognized for many decades that myeloma that comes out of the bone marrow and bones, for instance, in soft tissues, in organs, tends to be harder to treat. That seems to be the case also with CAR T cells. So there may be unique kind of biologic features of myeloma that tends to come in the liver or kidney or heart or lymph nodes, other organs, that is different from the regular myeloma that remains constricted to the blood and bone marrow and bones. So that's the other aspect, the aspect of the nature of myeloma, the microenvironment, the region in which the myeloma cells reside, etc. That might predict also why these treatments stop working eventually.
Okay, other question?
As a follow-up, what criteria do we need to have a second time with the CAR T cell?
So right now, there are two FDA-approved CAR T cells. They both target the same protein, BCMA. Okay. There's not a lot of data to guide us whether patients who receive one of the CAR T cells responds well, the disease comes back 2 years later, could we use the second FDA-approved CAR T cell? Quite apart from the financials of it, which would be that they're both expensive drugs, not established to be used quite in that sequence. So scientifically as well, we have little data whether giving ide-cel after cilta-cel or cilta-cel after ide-cel would give us the same kind of efficacy. And often in that scenario, it would be reasonable to consider a bispecific antibody instead, which is much more readily available, don't need to manufacture much. But if the alternative is to use a CAR T cell that targets a different protein. Right now, that's available only as clinical trials because the GPRC5D CAR T cells, there are several clinical trials, but none are FDA approved. So the criteria to qualify for that would be dependent on what the criteria of the clinical trials are, which would be usually organ function being okay, myeloma clearly having progressed from prior treatments, etc. But we have several patients who have received sequential CAR T cells with good effect.
Okay, a couple more questions.
Quick question.
Yeah.
Can you join a clinical, is there a time limit to join a clinical trial, or you have to start it?
Not at all. There's no time limit to start a clinical trial. It is dependent on circumstances. There are clinical trials for patients with newly diagnosed myeloma. There are clinical trials for patients who have had 1 or 2 lines of treatments. There are clinical trials for patients with 5, 6 treatments. At any stages, there are different clinical trial options.
No, but I'm saying a clinical trial that's ongoing. If someone says, okay, I want to join, can you join it if it's already started?
Yes, you can. So the trials run over a period of months and years, typically. Each trial sets out at the beginning to say we're going to treat 20 patients, 50 patients, 500 patients, whatever the number is. And we keep enrolling until we reach that number. Well, if it's 20 patients, it's 20 patients. If it's 500, it typically is open in multiple sites across the country and the world. And we keep enrolling patients as long as the study is open. Now, once we've reached that number, we close that study out. But many centers like ours continually have new trials that open. When one study closes, we look and see what else can we do in the same space for other drugs or treatments. So there's often clinical trials for all the different kind of stages or phases of multiple myeloma, to be honest.
Hi, thank you so much. You touched on this at the beginning of your remarks, but I guess I'm just curious from your experience to hear a little more about what relapse can look like in different forms. You said sometimes it's obviously a slower burn, sometimes it's much more acute. I'm kind of curious to get a picture of that and when you decide to seek treatment.
Yeah, so this is a good question. So I guess what does relapse look like? It varies. There are 3 or 4 patterns of relapse, I would say. Number one is obviously once you're diagnosed with multiple myeloma, you're followed pretty closely with your doctor every 2 months, every 3 months, typically at some frequency while you're on maintenance or follow-up. And most patients, I would say, relapse where their markers slowly go up. So their M spike was 0, let's say, at its best, or 0.1. You go to the doctor, you do a labs, and now the M spike is 0.2. We wouldn't immediately do anything because it's a small increase and maybe just a variation or but the next time you come in, maybe the numbers have gone up a little bit more, 0.4. Now we're starting to see a trend. And so oftentimes when that happens, patients are completely asymptomatic. If they were not getting these labs, there would be no reasons to think that the myeloma is resurfacing. But as the numbers go up, again, each patient and doctor will know what's the best way to handle this. If this is somebody who has very low levels of disease slowly progressing, it's fine to watch this for a little longer to see how quickly does the number go up. Is it changing week to week? Is it changing month to month? Is it taking several months to change? At some point, the doctor will decide maybe we need to reassess. Like for instance, getting a PET scan to see if anything has changed, getting more laboratory testing, getting a bone marrow biopsy, etc. And so that's probably the most common pattern where the numbers slowly, steadily creep up over a period of weeks and months. The second pattern is where the numbers creep up more quickly, i.e., you see a number that was 0 at one visit, 2 months later you're getting a labs done, now suddenly the M spike is 0.5, 0.6, so pretty insignificant. In those cases, usually the doctor, once they come back in 3 months, it would be either let's do all these testing now or come back in 3-4 weeks, let's see whether the numbers are changing quickly. So that's the second pattern. In this scenario as well, the patient is still asymptomatic, has no symptoms. The third scenario is in addition to the labs changing, we're also seeing changes in other laboratory parameters. Maybe the hemoglobin's gone down a little bit. Maybe some changes in creatinine. So patients may feel well if their hemoglobin goes from 13 to 11 because it's still pretty decent numbers, but the labs may show a significant change. So there are now some symptoms or laboratory symptoms, but not clinical symptoms. So those again, with the sense of urgency is a little bit different. We would want to act more quickly. The final scenario, which fortunately is the least common, I would say for the most part, is where we have actual symptoms. The patient calls us and says, I have a new back pain that I did not have, or I'm feeling very, very tired the last few weeks that I've not really felt before. And that would prompt us to say, why don't you come in, let's get some labs, and those labs will then tell us, unfortunately, that the numbers are going up, or anemia, or some other features where we would act much more quickly to change treatment, start new drugs, new therapies, etc. So those, I would say, are kind of the 3 or 4 different ways in which most patients relapse.
Okay, we'll just do one more question before lunch, and then save all the rest of your questions because we have a full faculty Q&A coming up.
I have an interesting question. I've been diagnosed a long time ago. I started with VAD or with thalidomide, and I had a stem cell transplant. And I've had an N protein, and I've been on a constant maintenance type of therapy. Now I have Velcade and dexamethasone and Pomalyst at this time. But all of a sudden, about a year or so ago, a second M protein came up. I now have 2 M proteins, M protein 1 and M protein 2. What is the significance of having 2 M proteins?
Is it of the same kind, like IgG, or is the second M protein a slightly different variety of M protein?
Doesn't really say. I have to have my
I'll answer the question in
latest
generality, but I'm
record
happy to take a look at your lab afterwards. But in
Yeah.
general, we do sometimes see when patient's immune system gets activated in some way, whether because of drugs, some other reasons, we can sometimes see other M spikes pop up. Typically, that's not considered a bad thing. Occasionally, the nature of the M spike can change a little bit where it's measured in 2 different regions. So even though it's a single M protein, the lab may call this as 1 and 2. So if that's the case, we typically, when we're looking at this, we would add up the 2 numbers to say, so it depends on exactly what nature the M spike had. So I'm happy to take a look at the lab afterwards and answer that question.